I still am, an Improving Global Health fellow with Health Education England, and also a GP in Bristol coming towards the end. So initially, this was meant to be an in-person placement in South Africa, and then obviously due to events, all placements were cancelled. And the team at IGH were racking their brains and actually did a really good job of kind of coming up with an alternative for us. And they offered us an idea of trying to do our placements virtually. So usually the fellows would have gone and spent 6 months or so in a resource poor country, aiming at developing leadership skills through collaborative projects. And that was places like South Africa, Lesotho, Myanmar, Cambodia, and Zambia, to name a few. And so when COVID struck, they came up with this idea for virtual partnerships, and we were offered to do the virtual partnerships or to hold off and see if we could go. At the time, we all thought maybe we're over in a couple of months and we could wait until next Feb and go, but here we are a year and a half later. So the virtual partnerships would be 1 day a week, and I was placed with, by chance, other family medicine trainees in Lusaka, in Zambia. Some of the other fellows were placed in South Africa, Uganda, Lesotho, Myanmar. Unfortunately, that was a really tricky placement for the fellow that was in Myanmar because of the military coup that happened. For my placement with the family medicine trainees, we didn't have an initial project, which I think was a positive thing, because I think actually taking a project that had been in person and face to face and trying to mold that into a virtual one would have been really tricky. So we didn't have a project initially. It was up to us to find something. My main collaborators have been Dr. Mukasa and Dr. Kunka, who are third year trainees in Zambia. And initially we met over Zoom, racked our brains for quite a long time, it seems like. And then we came up with this idea of sharing resources and sharing learning surrounding quality improvement. The trainees in Zambia felt this was an area they'd really like to know more about and incorporate into their clinical practice. So we developed some online Zoom teaching that we got together on Zoom. There's 10 trainees in Zambia, and we all got together on Zoom, shared the knowledge on quality improvement. Then the trainees actually went away, split into 2 groups, depending on which hospital they were in, and came up with some great ideas for quality improvement projects in their workplace. And we all met back, shared those ideas, talked about them, and talked about how it might be possible for them to put them in place. And that's what we're up to at the moment. So I'll let them talk about that. Some of the things I've found positive from this. So I think I was really, really lucky with who I was placed with. Family medicine trainees, especially Dr. Kunka and Dr. Mukasa, have been amazing, so enthusiastic. So I think I've been really, really lucky with my colleagues. I think that's really important for a virtual partnership. You've both got to be engaged. The IGH team were also really great, very supportive. You had an in-country lead who could guide you, a mentor who was separate from the project really, and would sort of help your leadership and your strategic development. And then also the team at HE who run the project were very supportive. I think one of the positives I took from it was that we created the project together. So I really feel like it was a relevant project, that the trainees came up with the idea and we moulded it around that, and also tried to get some feedback as we went along to make sure it stayed relevant. Using SurveyMonkey I thought was really good, because it just allows everyone to stay anonymous so they can give honest feedback. I carry on with my GP training alongside, so I could be at home and get that done. So that was really nice, and it's added a bit of variety to my job as well. And then on a more personal level, I found it actually provided a lot of support during COVID. we shared personal and professional stories of COVID, and I think that created a sense of, for me, togetherness and solidarity when it's quite an isolating time. Yeah, and it just reminded me that it was possible to have interesting projects and working with interesting people, all from your own home. Things I think that were difficult, internet connection, which is the same with in any country, I think. I'm sure there's not been a Zoom I've been on where someone's internet hasn't dropped out, but that can be really tricky if you're trying to build rapport, if you're trying to discuss things. It's hard to get the flow going if people are dropping in and out, and ensuring that the project you're doing is relevant. I've never been to Zambia, so I did initially feel quite daunted about doing a project in a country I'd never been to, and worrying that I was going to get it wrong or not do something useful because I didn't know the country. But I think that all comes down to good communication between you and your colleagues, and being open to different ideas. And then quickly, who can apply for IGH? Mostly anyone really if you work in the NHS. So you have to have done F2 if you're a doctor or a dentist. But yeah, very broad that people can apply. And I think band 6 if you're a nurse. And then here's the link. Although sorry, that's covered a little bit by my people here. But if you just Google IGH Health Education England, it's quite easy to find. Or I can put it in the chat later. And then I'll pass over to the family medicine trainees in Zambia, Dr. Chile and Dr. Nakonde. Hopefully we've got you. Give me a shout.
Hi.
Hello.
This is Dr. Chiwe Zile from Zambia.
Hi. I'll stop sharing. 1 second. You carry on. Sorry.
Hello everyone, this is Dr. Nkonde Bell, or you can just call me Bell, from Zambia. I'm a first year family medicine registrar.
Great, hi guys. Did you want to screen share or are you just going to talk about the projects you've been looking at?
Okay, I can share the screen.
Yeah, sure, great. Perfect.
Okay, so we're given a task as a team to come up with a QI project, and I think we've been working with Emily for a longer time. She's been guiding us through, and I think we came up with QI projects, and which I'm going to share now. Let me share my screen. Okay. I don't know if everyone is able to see.
Yeah, looks good.
Yes, we can see the screen, Dr. Nkonde.
Okay, let me start talking about ourselves. I'm from a hospital called Chilenje Level 1 Hospital, which is now a second level hospital. And on my far left, those are my colleagues. We are all first years. We have Dr. Zimba. There is I in the middle there, and then Dr. Chilando. And then on the other side, that's me providing healthcare to our patients. I'm in theater there, performing some operations. And there, the other picture is also talking, it's me there, being taught how to perform certain operations. Okay, so we are first year registrars currently providing healthcare at our facility, primary healthcare at our facility. And I'm currently in obstetrics and gynecology. And then my colleague Zimba is in internal medicine. And there is also general surgery, which is Chilando. Yes, so our hospital provides care for about 300 patients on average on a daily basis. And we provide inpatient and outpatient facilities as well as surgical services. Though we may have low resources and still do our best to provide the best care we can, here are some of the aspects about our service delivery that we think can benefit from a QI project. So the first one is that it has been noted that at our facility, which is Chilean General Hospital, there's been a delay in the decision to incision in doing emergency surgical procedures. This has led to poor outcomes and has hence affected quality health care delivery. So we came up with a fishbone analysis, which I've displayed there, in coming up with factors that have affected the delay in decision to incision time. So the first one is the health personnel, which is on my far left. And the second one is the laboratory, which is on my far right. And on the bottom, there's a patient aspect and the theater. So under health personnel, certain factors that we thought are affecting the delay in decision to incision time when doing an emergency operation. Number one, we said there is limited number of skilled workers. Number two, there is a poor attitude. Number three, there is poor communication amongst our health providers. The other one, the laboratory, the first one, we thought the problem was the capacity of the lab is unreliable. The second one is that we have outdated machinery. And then under the patient problem, what we discussed was that there is a delay in obtaining consent from the patient. And then the other problem is that certain patients are unstable for theater. So under the theater, we are saying there is limited space. Number two, we have inadequate basic machinery. And the last one is that there is limited medical surgical supplies and drugs. So I'll spend a few minutes to explain each one of the problems and also the solutions that we thought would help in improving our QI. Okay, so the first one was the patient factor, and the problem that we discovered was that there was delay in obtaining consent, and which may be due to the first one. We thought there was lack of autonomy due to traditional beliefs of hierarchy or being a minor. So we have situations here where actually we believe certain decisions the patient cannot make them because of this traditional hierarchy. For example, maybe a woman who is being operated on and needs maybe an emergency cesarean section, and then she has to consult the husband for her to give, for him to give consent. So that has affected in our delays. Sometimes also we have a situation where we have minors, and then it's very difficult to operate on a minor without getting consent from the next of kin. The other problem that we discussed was that the patient may not be well informed about the procedure to provide consent. So we have situations where maybe we explain the procedure to the patient, but they still do not understand, and the delay in making consent. So what we thought would be the solution was, number one, was to educate a health education on the importance of the cesarean section delivery as a mode of delivery. Maybe people believe that maybe the only form of delivery is maybe it's just the normal way of vaginal delivery. But if we educate the patients on the need, I think that will also reduce on the gap. Number two is advocate for patients on consent for operative delivery when benefit outweighs risks. So also we need to advocate and teach our patients to say there is the risk, the benefits of doing an operation obviously outweighs the risks. And then the second problem was
Val, I think we've lost you, lost your sound.
I lost the connection.
That's okay. We can hear you now.
Okay. Is my presentation still there?
No, we've lost that actually.
Okay. Let me share it again.
Yeah, great.
Okay. Is it there now?
Yeah, it's on the screen now. Yeah,
Okay.
you can see the
Yes, we
cursor.
can see it.
Okay. So under health personnel, I was saying that there is poorly motivated staff. And then the second one was a limited number of skilled workers. The hospital at times may only have one anesthetist or a surgeon at a given time. So we have situations where maybe you have 3 emergencies, but you only have a limited number of health workers. And this has affected on performing emergency operations. The other reason is maybe there is a lack of teamwork and agency as a problem that has affected us. So what we think were the solutions are: number one, we needed to establish an effective method of motivating staffs and encourage teamwork, and commonly such deliberate workshops and training in attitude change. For example, maybe we come up with a program of maybe a small campaign so that maybe we will motivate health workers. Number two, maybe anticipate the need for operative delivery and ensure IV access blood work is done on each mother admitted for labor. So this is where now because we usually most of our patients, we do not manage them as high risk. For example, those who are pregnant. So we have situations where maybe if there is an emergency, the patient doesn't have an IV access, we don't have a baseline full blood count, and then that also affects in the delay of actually doing the operation. The other one is to advocate for increased staffing, especially during the weekends. So usually over the weekends we have limited number of health workers, so it's very difficult to manage emergencies. So the third problem is the laboratory. Under laboratory, we have the capacity of the lab is unreliable due to, number one, there is poor maintenance of machinery or outdated machineries. And number two, there is erratic supply of reagents due to limited resources, and sometimes a non-vigilant procurement process. So solutions, we think we need to advocate for new standard laboratory machinery. Then the other one, we need to ensure that the procurement process of reagents is improved to become efficient and sustainable. And the last problem is the theater. Why the factors that we thought would data first in the theater is that, number one, we have lack of adequate theater space. Number two, we have inadequate medical supplies and drugs, which may be due to maybe limited resources or ineffective procurement process. So what we thought is the solution is that, one, we advocate for a new infrastructure to have theater space designated for emergencies only. And the other solution was to advocate for a new machinery or more effective procurement process for medical and surgical supplies. And then the final problem that we identified, and there are possible solutions. So we're given a task to say, under the QI project, the fishbone analysis, usually we have to choose a problem that we can work with, which is measurable, and then we work towards that. So we sat as a team and we came up with one problem. And then we discovered that the biggest challenge that we have that has actually affected the delay in decision to incision time was a poor attitude of health workers towards work, which is due to maybe lack of motivation. And then the solutions that we thought, number one, was to establish effective methods of motivating staffs, which I talked about, a small campaign, and number two, training of health workers on basics of managing emergencies, which I think we want to start working towards this problem in the remaining time of the year, December, part of November and December. I think this is our main focus as a team to work towards improving the attitude of health workers in managing emergencies. And our achievement on the QI is that as a team, we managed to engage stakeholders and came up with a collective decision of the most important factor affecting the problem identified. So which is, we had a meeting with all stakeholders, the nursing officer, we had the medical superintendent, and we had the in charges of all the wards that are affected. And then we discussed the problem to them. And then we came up with a solution to say the biggest problem that we have is actually poor attitude. And currently, that is where we are as a team. And we are working towards improving this particular problem. And this is the end of my presentation. Maybe I can get some questions. Thank you very much.
Thanks, Belle. That was so interesting. Thank you so much for sharing that.
Thank you.
And just before we do questions initially, Belle, is it just one presentation we're having, or is it two?
There are two. There are two presentations.
We might have to. I think just timing wise, we might have to. Lucy, what do you think? Move on. If
should we have the second presentation and then have questions all together?
Sounds great. Yeah. Does that sound okay, Belle?
Yes, yes, that's okay. So my colleague is going to present next. Yes, Dr. Chibwe.
Okay. In Zambia, it's evening. Good evening. I'm sure everywhere it's afternoon.
Yeah.
Yeah. So I present on behalf of Kanyama because we have two groups. That was the Chilenge group, and then we have the Kanyama group. So that I may want also to share my slides so that I think I can share my slide as well.
Great.
All right. So on behalf of the Kanyama group, my name is Dr. Chiwe. I'm a first-year family medicine registrar at the University of Zambia under the School of Public Health. So as Emily has said, we are also tasked to actually come up with a QI project at our facility, which is Kanyama General Hospital. And we identified our problem that I'll be able to share. So just a brief introduction of what Kanyama is. Actually, Kanyama General Hospital is a second level hospital, which is located in one of the best areas of Lusaka. I think just like in my previous friend, it has also been upgraded to a second level hospital from way back. It used to be clinics. So I think you can see that picture. I think that's a number of our registrars, except our visiting lecturer from the City Grove, that is Dr. Mayhew. The rest are our registrars. We have the first year, second year, and the third year. I think the fourth year was not around that time. So just a brief background of at Kanyama General Hospital. So it started as a clinic. I think that was in the year 2000, and it was upgraded to a health center around 2005. And in 2012, it was actually named as a first level hospital. And it started offering a lot of services like dental services, inpatient for female and children and male, ART, and many other services. Then because of the SDG number 3, which was pronounced, so our Minister of Health thought that it needed to be upgraded so that at least we could meet the SDG number 3.1 and 3.2, which states that, 3.1 states that by 2030, we have to reduce the global maternal mortality rate to less than 70 per 1,000. Sorry, pardon my mistake there. Per 1,000 live births. Then SDG number 3.2, it states that by the end of 2030, we have to prevent death of a newborn and children under the age of 5 in all the countries, and to reduce the neonatal mortality to at least as low as 12 per 1,000 live births, and under 5 mortality to at least as low as 25 1,000 live births. This is because us as developing countries, we've been having very high mortality rates in terms of under 5s and the neonates. So the statistics that we normally see at Kanyama, just labor ward in 24 hours, at least we're able to deliver about 34 live births in 24 hours. And OPD attendances, we normally see approximately 376. And then dental services, at least about 30 are screened and seen. And MSH services, we have about 36, which are seen in 24 hours. And theater strokes, cesarean sections, at least we have 4 cesarean sections in 24 hours. And VMMC, at least about 16. And cancer screenings, at least about 5 patients are screened in 24 hours. So during our problem identification, we identified that we had a high neonatal death, a high mortality in neonates at Kanyama. That was one of our outstanding problems that we identified. And then we came up with a small fishbone outlining some of the factors that could be leading to the high mortality rates that we experience at Kanyama. So to just dissect the fishbone, one of the problems was identified that it was due to poor antenatal quality, which was being offered, such that the mothers were not being prepared very well. And on my far right there is poor working environment. And down, there is inadequate equipment. And we have human resource issues, which is deficit as well. So I'll go into just dissecting each of them. So in detail, we have actually a human resource problem. We have inadequate number of midwives, which are actually working as the establishment. And that could be because of the employment, which were not affected. I think the solution to that was that there has to be employment of midwives. And we are happy that our government, I think the recent budget which was presented a week before, I think last week, they mentioned of employing at least about 11,200 health workers, in which even the midwives are included. So we expect that to beef up this so that at least the human resource deficit could be worked on. And then we have inadequate skills. And this has been observed because most of the midwives that we have, actually they lack some skills in neonatal resuscitation, most of the time. So, and we attributed this due to some of the midwives have never had any refresher courses in their lives. And also the general nurses who are allocated to work in labor ward also may not have adequate skill in neonatal resuscitation. So we thought that to solve this problem, it needs funding. So we've been rehearsing with our head of clinical care so that maybe he can look into this issue so that if we are funded, at least we can organize some refresher courses for these midwives so that at least they can have at least some skills in resuscitating neonates, especially when they are faced with a challenge. Then the other problem was the attitude. So the attitude that we have with our midwives in our labor ward is that they lack what we call the response system. So the response system is a situation whereby whenever they are faced with a neonatal emergency, they don't alert the system so that at least they could be beefing up of staff so that the process could be managed very well. But most of the time you discover that the time that they are coming to shout that there's an emergency, maybe the child is no longer responding. So we've tried to work on this by formulating up more like I would say more like a form to indicate the midwives who are on shift. And in case of any emergency, what did they do, so that whenever we have what we call as quarterly meetings to review some of these cases, then we are able to identify the midwife who was there, what happened, what she do, did she call any doctor to come and attend to the neonate. And there's also what we call as a delay in taking action when a neonate not doing well. I think this is coupled together with the response, because most of the time you discover that it clicks to them that this is now an emergency when the baby or when the neonate is already passed on. That's when they'll be moving. So the same form that we created actually even tackles for this as we try to solve the attitude towards the neonates. Then we have another problem, is the environment that we work in. So we don't have what we call as a neonatal emergency preparedness. And this is because we don't have a running emergency trolley. Even some emergency drugs in our neonatal resuscitation room are not, I would say, are not there, because if I say they are readily available, but they are not there. So which has been actually a big problem, because whenever we are faced with such a challenge, you would find that if I want to intubate a neonate, I don't have a neonatal endotracheal tube, or I don't have maybe something to use. So I can't use a big laryngoscope because it may hurt the child. So we are working on this. I think we rehearsed with our head of clinical care, so that at least we can be supplied with some of the emergency equipment that we need, especially in neonatal resuscitation. Then the other problem was about the antenatal. So we've noted that there have been poor follow-up during antenatal. And this has actually been witnessed most of the times. We just experience that the mother is coming and her BP is actually quite elevated. She's even in severe preeclampsia. So this could have been because during the antenatal visits, maybe the midwives who were doing the antenatal checkups maybe did not pick it up from there. And we've been having a situation whereby maybe they'll just give a start dose of an antihypertensive and the mother goes home. The time that the mother is coming home, you discover that the blood pressure is quite high and uncontrollable. So to solve this problem, we've trained the midwives in those areas, such that when there is just an elevation of the readings, 25% from the normal, that was the first antenatal attendance, at least they should seek the advice of a doctor so that that mother could be managed very well. Then we have inadequate screening tests, especially the torch tests. I think this one has been a challenge because it has been actually very difficult to find it, but I think we're working on that. We hope that the higher officers will work on it and procure on our behalf. Then we don't have actually, we have inadequate IEC so during antenatal visits most of the time, and we've engaged our midwives so that whenever these mothers come for antenatal visits, actually they are taken through the process of antenatal, labor, and postnatal, so that even when they're coming, they are in labor, they are well prepared and they know what they'll find in labor. So like the equipments, we don't have the resuscitative equipments, which I said we'll be working on. And I think our HCC will be able to actually help us in procuring. And also we don't have a CTG so that we could be monitoring the progress of labor, of which all of them we anticipate that they'll be procured in due course. So the final problem identification and the possible solution was that we needed to build or set up an emergency trolley running in our labor ward, so that whenever we are faced with an emergency, at least we are able to get some drugs and some equipment from there. And then the other problem was we need to provide basic training in neonatal resuscitation, because majority of the midwives who are working in there, they've never had any special skills in just neonatal resuscitation. So we feel when we are funded, we'll be able to actually come up with an in-house training so that we can train these midwives in neonatal resuscitation, so that at least their knowledge could be refreshed. So I just put up, I think that is our resuscitator. It's non-functional. I'm sure you're able to see. So all those, we need to work on them so that at least we can have a fully functional resuscitator. I think you cannot see very well, but because I'm very familiar, so I'll just try to explain those labels there. So the red there, it shows that that's where our emergency storage is supposed to be. But if you zoom like the way it is, you can see that there isn't much as in terms of emergency. So that's what we've been working on. So that I think in the next presentation, we'll be able to give a testimony that this is what we've worked on. I think from Kanyama, that was our presentation. Thank you so much.
Thank you so much, Dr. Chibwe. That was so interesting, and great both of you to have had photos so we can really see what it's like as well. Thank you so much for sharing that. I'll pass back to Lucy.
Thank you.
Thank you so much for those fantastic presentations. And yeah, I loved all the photos, and it's really nice actually seeing how you've used the QI training and the fishbone analysis and actually really put that into practice in your context and how it might differ in some of ours. So that's really nice to see how it works sort of across the board as well. Could you possibly click stop sharing on your screen just so that I can see who's got hands up, and then we can take some question and answers. Just to say, as while I'm waiting for you to do that, Kerry has certainly shared our view to Kerry Jones, who I think we all know of as the guru of quality improvement and delivers QI across Kenya and is the QI lead for THET as well, has said in the chat, again, this work is outstandingly good. Do you think that the staff attitudes partly related to lack of confidence in dealing with emergencies? Do you think that some of your staff training needs could be met by remote learning? So while everyone else is thinking of questions, I'll just maybe put that question to you. Hopefully you can see it in the chat as well. Do you have any thoughts on that? Maybe.
You're on. So it is on after all. Thank you.
Belle, or I don't know, perhaps, do you have any thoughts on Kerry's questions?
Dr. Chibwe, did you think, I don't know if is your internet working still?
Come again?
Yeah, we were just wondering about, can you see the chat? You might not be able to actually. We were wondering if you thought that any of those issues that you highlighted in your presentation, if you thought that any of the training needs could be met by remote learning?
Yeah, I think remote training could also work. Yeah, I think so. Yeah, because most of the time, the problem that we have in Africa is network and all those issues. But I think we can try it. I think it can. Yeah, it can work, yes.
Thanks.
Sorry, Emery, I would love to just echo what Dr. Chibwe has said. I think if we had some kind of remote learning, it would actually improve things. And I think we could have some kind of back and forth where we have some kind of lesson, and then we try to implement. And probably if you've got a case, you can bring it up, and then it is discussed so that we see how we continuously improve on the performance, especially of, say, neonatal resuscitation. Yeah, so I think that it's more of a continuous process rather than a once-off learning thing. So I think it's a good idea if it can work.
Yeah, I totally agree. It's a continuous process. Yeah, thanks, Dr. Kunka. That's really helpful.
And Donal, you've got your hand raised. Please do unmute. Yeah, thank you.
Yeah, great presentations there from the Zambian team. I really enjoyed them. I was struck by how the issue of staff motivation and staff attitudes is similar probably the world over in resource-rich settings and resource-poor settings. So even if you improve the hardware in a service, such as a hospital or a clinic, you still have to deal with staff motivation, staff attitudes. And I think that's a problem that's going to exist forever. And I suppose one of the things I've learned during the COVID pandemic is the value of resilience training for staff. And I remember from my periods of time in resource limited settings, how resilience is often much better among staff. And that's something I think we can learn a lot from, particularly from our Zambian colleagues as they've outlined. So just a thought.
Emily, did you have any comments on that? Or?
Yeah, I totally agree. I think it's a worldwide problem, attitudes, and yeah, with the best machinery in the world, unless you have people who want to use it and are motivated to use it, then it's not going to work. And I agree. I think we see that in England as much as you would see it in Zambia. So we can really, I think, relate to those issues. And we certainly have been sharing those experiences with the Zambian trainees. Thanks for highlighting that as well. Yeah.
Thank you, and thanks so much for all your input as well for the conference and the questions. Really appreciate that. Does anyone else have any?
I think Dr. Mpundu has.
Oh yes, I can see the hand up. Thanks, Emily.
Yeah, thank you so much. I just wanted to comment on the poor attitudes. I want to agree with the previous speaker that it's actually a hard one, but I suppose maybe just a continuous reminder through training, such as the SMILE campaign that Bill had talked about, would actually help in improving the attitudes. And also maybe providing non-monetary incentives. I think that could also be another way. So I think there could be ways of, trying to get people to, improve their attitudes. It may not just be monetary, ways or incentives. Okay, thank you.
Yeah, thank you. I totally agree. I think there's lots of ways to incentivize people, even as we've been talking about this afternoon and this morning, with having things that allow people to pursue interests at work that they're interested in as well. So just an example. Thanks, Mpundu. That's great. Don't know if you've got any more questions, Lucy. So.
I wanted to comment on the issue of training. I think in terms of competence, I've also seen some of our colleagues who are very willing to help, but then they don't seem to really have evidence for what they're doing. Yeah, so you can see that this person is really interested in what they're doing. They would love to help, but then what they're doing is not backed by any evidence. So it's either it will help, it might not help. Yeah, and so I feel like the plan by both teams to kind of provide some training in the particular area of their QI actually help in improving outcomes, because then you have people who are willing to work. They are also doing things that are kind of evidence-based. I think then you can be sure that at the end of the day, it might be of help to the patient, to your client that you're trying to help. Thank you very much.
Yes, thanks, Evereste.
Thank you so much to everyone for your really interesting comments and sort of probing thoughts as well as to, you know, I think what really comes about from this is that, you know, we've heard from so many different countries today, and I kind of come back to what Jane said at the start as well, is how actually hearing from this is that we realize how we all share the same problems, no matter where, or the same challenges, and share the same successes. And it makes us realize as well how we could all do things better, no matter where we're placed. So I think for me, that's what's really come out today. And, you know, how it doesn't matter where you are, sort of from the virtual electives, how much joy everyone gained from doing that virtual electives project. And yet a lot of people were facing similar sort of challenges and successes, and same with the QI. I don't know, Kerry, I know that you put a comment in the chat. I don't know if you want to make any sort of, obviously those last two presentations were very QI focused, and I feel that having you here today is a real asset to the conference. And perhaps, I don't know if you want to make a comment about that, or share any sort of pearls of wisdom with the Zambian team, or words of encouragement perhaps.
Thank you, Lucy. Well, certainly words of encouragement, because I think what we've heard is actually really outstanding. And so congratulations all round, and including to Emily, because I think you've shown us how well this can be done. We've taught a lot and teach a course in QI and leadership in Kenya, and have done it so far in person. But I've had doubts as to how well this could be done at a distance. But I think you've shown us really something very important today. So thank you very, very much, because I think these are outstandingly good, and you've made great progress, and there's much to build on, I would say. So I would just say really well done. Thank you for showing us a new way of doing this. And I look forward to seeing a lot more of it in the future, and it will encourage all of us doing this kind of work to be a little bit more imaginative about how we can do this. So thank you all, well done.
Thanks, Kerry. We're going to sort of draw to a close now in the conference, but I don't know if anyone has any. Please just feel free to sort of unmute or chip in if anyone, or raise a hand if anyone has any comments on anything that they've heard today. And particularly, we were going to try and open a discussion on sort of how partnerships can work together, and what we can learn sort of post-COVID. I feel that a lot of that has come out throughout the day anyway. So really just to open it up to the floor, and if anyone has any specific comments, thoughts or questions, please do chip in. Otherwise, we will make this recording available to everybody.
One thing I've been sort of thinking throughout the day was, obviously there's been so many wonderful ideas and so many great presentations, and so many people doing great things, but it was just how to sort of not kind of for that to get lost, or I didn't know there was a way of having all these ideas or what's going on in one place so people can see and start collaborating. But it's just something I've been thinking about throughout the day, and I'm wondering how we might be able to do that. Yeah, just something to think about. I don't know, so obviously the first thing that springs to mind is, you know, classic Facebook or Instagram, I suppose, but I don't know. Yeah, I don't know what everyone else's thoughts are on that, but seems like I just sort of don't want to end today and then be like, oh, we're not going to speak again.
I think that's really important, and I know you were at the morning session as well, Emily. And I think with all of this, there's so many shared ideas and shared thoughts, and what we kind of want to harness this energy and enthusiasm as well, and not lose this, but also work out how we can work more collaboratively together in the future. Not just between our networks, I think, but between our wider countries. And, you know, you have partnerships in Zambia. We've heard from 2 different Rwandan groups today. You know, they're probably not even collaborating together within their projects, similarly as we're not in the UK. So I think how we can share all this information is and create opportunities for each other, and opportunities, you know, we've just heard 2 fantastic QI presentations, and I know that there's a lot of QI projects going on again in Rwanda, in Kenya and Uganda, and how we can sort of cross-pollinate those. I think that's food for thought. If anyone does have any ideas, please do get in touch with us. We'd be really grateful. Oh, I've just seen we've got a few messages. Any questions in the chat? No, just lots of thanks, really, to everybody. Okay, well, I'll just wait. Final call for any questions.
Can I just make one comment that kind of similarly kind of echoes Emily's point around, you know, fostering these kind of collaborations, and I guess part of it as well is sharing the opportunities, isn't it, and making people aware that, you know, there are opportunities out there to get involved and to share our experience, because I appreciate lots of people are doing this in their spare time. They're doing it on a voluntary basis, and you know, there's clearly already here a lot of passionate people who want to do things, and I think if we can help share the workloads of some of these projects and keeping these things going, then you know, I think that can only be a benefit for everyone, really.
Yeah, I think that's absolutely right, Craig. I think that's absolutely right. Thumbs up there from Kerry and others. I think that's a really good point. I think it's, and for those of us that run sort of global health networks as well, I think it's certainly something that I sort of lie awake thinking about in the evening is we have so much interest from loads of people from the UK who've got in touch and said we want to join the collaborative or the steering group. And even when I'm in, my background is mostly Kenya, but even speaking to a lot of the Rwandan team as well, who I've got to know a bit more recently, but there is so much interest and enthusiasm out there, but how we bring that together and really make the most of it and really make people feel part of something and part of something bigger. I'm not sure there's an answer yet, but I'm sure it will. And I think it's sessions like this, you know, we're all gonna, well, if I know that I will be leaving on a Friday afternoon high after this conference, and hopefully everyone else will be too. And it's just great seeing all these various people coming online together. So thank you.